Greetings. During the past several months, we've learned a great deal about patients suffering from COVID-19, including the serious morbidity and mortality associated with the disease. The daunting challenge of saving patients who develop severe acute respiratory syndrome is enormous, given that this disease is associated with both immunologic and hematologic systems gone wild. There is no specific antiviral treatment, and anticoagulant and anti-inflammatory therapy is supportive only. Performing urgent life-saving or limb-sparing procedures, in addition, represents a complex clinical challenge. The pathophysiology of COVID-19 involves a virus-induced inflammation that triggers a cytokine storm causing tissue factor release, thrombin generation, fibrin formation, which is designed to coat the virus, and these fibrin coats are supposed to also protect the endothelium and prevent the virus from spreading. Now, while that is a very incredibly important mechanism for the survival of the organism, it's associated with a serious side effect, which is thrombosis. Once this clotting system gets activated, then the fibrinolytic system kicks in and attempts to break down all of this fibrin that's occurring throughout the body to keep the fluidity of the blood open. And as a result of that, you have fibrin split products and D-dimer products, which are also breakdown products of fibrin. And these circulating products we can measure, and they can indicate the severity of the disease. A DIC-like picture can result in thrombosis or bleeding, depending upon the consumption or usage of the clotting factors. And these can be measured by the various tests, including the ProTime, the partial thromboplastin time, and a platelet count, fibrinogen levels. Now, the balance between blood clot formation and blood clot dissolution and the rate of speed of that process will determine whether or not the patient exhibits clotting or, in addition to clotting, exhibits a bleeding tendency due to a consumptive coagulopathy with prolongation of the clotting tests and the lowering of the platelet count. In this disease so far, the overwhelming feature is that of thrombosis, not of bleeding, with the exception of microvascular thrombi that may occur in the endothelium of the lungs. Here we see a picture which depicts the endothelium in lungs along with the alveoli. And as the virus attacks the endothelial cells, it is hypothesized that a bradykinin-dependent local lung angioedema via bradykinin 1 and 2 receptors is an important feature of COVID-19. The authors of this paper propose that blocking of the bradykinin 2 receptor and inhibiting kallikrein activity might have an ameliorating effect on early disease by COVID-19 and might prevent the acute respiratory distress syndrome, ARDS. In addition, this pathway might indirectly be responsive to anti-inflammatory agents, and some investigators have employed other agents such as corticosteroids, nonsteroidal anti-inflammatories, and aspirin and antiplatelet drugs in an attempt to blunt this body response and the destruction of the endothelium and also of the alveoli in the lungs. And this is where we can see the hemorrhage in the alveoli and in the lungs, and that can be a major problem and occurs later on in the disease. This complex diagram depicts the changes associated with sepsis and the changes in coagulation and the immunologic system. They're inextricably tied. So in patients with sepsis, the imbalance in clot generation, coagulation, and clot breakdown, fibrinolysis, is a pivotal response that occurs due to host defense mechanisms, but it's associated with the development of organ dysfunction. As microvascular thrombi occur, they can damage the kidneys, the brain, the lungs, the liver. And the authors of this paper suggest that all of these conditions likely share a common pathway for the development of multiple systems organ failure. Diffuse activation of the endothelium by pro-inflammatory cytokines, leukocytes, and other proteins does occur. Activated endothelium becomes prothrombotic in its own right in these conditions, leading to the formation of microvascular thrombosis. In addition, fibrinolysis is inhibited, resulting in the buildup of fibrin thrombus, which itself is pro-inflammatory. A famous researcher in the early history of coagulation by the name of Oscar Ratanoff proposed a theory called the tangled hemostatic web, in which he showed evidence based on autopsy and physical findings in patients that indicated that there was an inextricable association between anticoagulation, coagulation, platelet function, and the complement and kallikrein systems. Furthermore, that the clotting system he postulated based on these experiments could be triggered in the absence of a formal antigen-antibody response that's seen in other diseases. Of historical importance is the effects of heparins and related agents that are not related to their anticoagulant activity. And here you can see a long list of those factors, and some of those would directly affect the immunologic pathways involved in this disease. And that is why the tendency is to use more and more heparin and earlier in this disease to blunt not only the possibility of clotting, it's not to prevent a major clot, but it's to prevent microvascular thrombosis and also the inflammatory changes based on the activation of the complement and kallikrein systems that occur with the invasion of the virus as a result of the cytokine storm. The American Venous Forum has put together something that's not to be considered informed practice guidelines, but these thoughts represent the available evidence of a group of venous specialists reviewing the current available literature and communicating also with specialists in high-volume centers in the U.S. and internationally. And based on all of this information is what these responses have evolved to. Some areas are controversial, and best patient management depends on individual patient situations. We've attempted to highlight these areas, and this document will be revised frequently as new information becomes available. All patients should receive heparin or low molecular weight heparin that are admitted to the hospital due to the high risk of thrombotic complications, including microvascular thrombosis. It is also important to take advantage of the non-anticoagulant properties of the heparins in order to blunt some of the immunologic reactions that occur as a result of the viral cytokine storm. Next, the question comes up, all right, now having said all of that and giving everybody anticoagulants, what in the world do you need to do a risk assessment for? Well, the committee felt that the risk assessment was important for several reasons. The committee also felt that the Caprini score was chosen because of its wide applicability in over 5 million patients in 25 languages and over 150 publications around the world. As a result of this enormous use of the tool, it's prevalent in many hospitals. And there are other tools. There are many roads to Rome. And some of the other tools have even better data in the medical patient. For example, the improved score with the D-dimer added. However, it has not been feasible, and certainly in the institutions that we're involved in, to have more than one score, and our institutions use the Caprini score. All of that having been said, getting back to why that should be done, is initially And by the way, this evaluation can be easily done by the family in case of very sick patients, and we recommend a family and patient-friendly form so that the onus is not on the healthcare givers to try to go through all of these things when the patient's admitted, especially when there's an emergency situation. But if the score is over 8, we recommend right at the beginning to double the dose of prophylactic anticoagulation. And if you take a look at the score embodies many of the comorbidities that have been associated with serious morbidity and mortality in this disease. We also take a careful look at BMI and double the dose of prophylaxis under those circumstances. Now, if the scoring on admission is not feasible, it's highly recommended not to omit the score at discharge due to the high incidence of post-discharge thrombosis. And rescoring the patient at discharge and using extended chemical prophylaxis for scores of over 8, elevated D-dimer values, a BMI of over 35, those patients with limited ambulation, and also those patients with heart failure. Now, I want to mention that the wonderful work done by Alex Spiropoulos and the improved score that is also associated with a positive D-dimer, and together they're linked and provide very high quality evidence in the medical patient after discharge for the use of prophylaxis with one of the direct oral anticoagulants. That is another option, of course, to use at discharge, but you have to remember that that score does not include all of the elements in the Caprini score, particularly family history of thrombosis and obstetrical complications, which could signal an antiphospholipid antibody syndrome that the patient is carrying. We have known for many years that most patients get their clots once they leave the hospital. Here we see that venous thromboembolism occurs in 77% of patients following hospital discharge and in 55% of patients after anticoagulation was stopped. Since that time, a large volume of data in surgical patients confirms the value of the Caprini score in identifying these patients. Now, years later, we have to deal with the same issues that are unchanged, except now we have the potential of the COVID-19. As stated previously, in the medical patients, there's recent evidence that an improved score of 4 or more with an elevated plus or minus D-dimer of 2 times normal identifies a 3-fold higher VTE risk population that significantly benefit from extended out-of-hospital prophylaxis up to 39 days or more with rivaroxaban or betrixaban without an increase in major bleeding. As we previously mentioned, we use the Caprini score, which incorporates D-dimer to select patients for post-discharge thrombosis. We found it very difficult to have more than one risk assessment tool for the hospital, and it has taken years to incorporate this tool at my home hospital. Introducing another tool at this time would not be feasible. Nevertheless, you certainly have the choice here, and again, I repeat, there are many roads to Rome. The committee further concludes that baseline blood tests should include a complete platelet count, blood count, PT and PTT, D-dimer and fibrin degradation products measured initially and serially. The initial dose of low molecular weight heparin we suggest to be 30 milligrams twice a day or 40 milligrams once a day, adjusted for renal insufficiency or a BMI of over 35. Those that have a creatinine clearance of less than 30 or acute kidney injury should use heparin 5,000 units sub-Q TID. Consider doubling the dose for scores of over 8, BMI for over 35, or heart failure. Again, rescore the patient at discharge using extended chemical prophylaxis for scores of over 8, BMI of over 35, limited ambulation, and all those with heart failure. The improved plus D-dimer score can be used as an alternative. Therapeutic anticoagulation is suggested for selected patients. Those with a D-dimer of 3 times normal, if not at high risk of bleeding. And we would like to point out that the direct oral anticoagulants are not suitable for inpatient testing. We recommend fondaparinux for those who have a concern for heparin-induced thrombocytopenia based on clinical suspicion. Mechanical prophylaxis is also recommended for patients at high risk of bleeding, including those with a platelet count of less than 30. Elevated D-dimers follow the severity of the disease and represent a marker of worse outcomes. Ultrasound screening is unnecessary if the D-dimer is negative. High D-dimers should not be the sole indication for duplex scan. Venous duplex scan indication should be similar to those in non-COVID-19 patients, such as those patients presenting with leg swelling, pain, erythema, and so forth. A normal venous scan should not be used as a marker that anticoagulation is unnecessary. We now know that pulmonary thrombosis occurs, and that it would be expected that patient would be expected to have a negative duplex scan. And we also notice in some of the large series that are coming out now, the incidence of venous thromboembolism is mostly pulmonary emboli, especially in ICU and those on respirators, where DVT under those circumstances is in the minority of patients. And that represents the serious vascular injury that occurs in the pulmonary circuit. Furthermore, patients treated with full anticoagulation should not be scanned except to answer a specific clinical question or if it's going to in some way change the clinical care. If scanning is required, we recommend the point-of-care ultrasound screening with a handheld or phone-held device that's preferred to using the big machines, certainly in patients with COVID-19. This also may minimize the technician's exposure. Here we see a diagram that summarizes the approach in these patients. Inpatients with COVID-19 should have a BMI, a Caprini score, and a D-dimer. And if the Caprini score is less than 8, BMI of less than 35, and the D-dimer is less than 3 times normal, low molecular weight heparin 30 BID or unfractionated heparin 5,000 3 times a day could be given. If the patient develops signs and symptoms of venous thrombosis, of DVT rather, we would recommend a point-of-care ultrasound screening. If it's positive, therapeutic anticoagulation. If it's not positive, continue the prophylactic anticoagulation. If, on the other hand, the Caprini score is 8 or above, the BMI is over 35, and the D-dimer under those circumstances is still less than 3 times normal, then we would advocate doubling the low molecular weight heparin dose. Finally, in those patients with a 3 times normal D-dimer, we recommend therapeutic anticoagulation with heparin or low molecular weight heparin, except for those patients at high risk of bleeding. Finally, at discharge, patients with documented VTE ought to have therapeutic anticoagulation for 3 months with a reassessment at that time. If the Caprini score is 8+, the BMI of over 35, and the D-dimer less than 3 times normal, we would add those patients with heart failure, those patients with limited ambulation. Direct oral anticoagulant should be prescribed for 6 weeks. If the D-dimer is 3 times normal, then regardless of the other variables, therapeutic heparin or low molecular weight heparin or a DOAC should be administered with follow-up in 2 to 3 weeks with a duplex ultrasound at that time. If the patients have a DVT, then therapeutic anticoagulation for 3 months and then reassess. Otherwise, the direct oral anticoagulant for 6 weeks. Finally, surgical procedures in COVID-19 patients. You can see the variety of risk factors that can be associated with this, with any patient, let alone patients with coronavirus. And there's an increased incidence of arterial thrombosis, DVT, pulmonary embolism, pulmonary thrombosis, stroke, fatal thromboembolic events requiring careful risk assessment of all of these patients. We advocate thrombosis prophylaxis for all at admission, including doubling of prophylaxis dose for scores of over 8, prescribing discharge prophylaxis for 6 weeks or longer when the scores are over 8, an elevated D-dimer, an elevated BMI of 35, limited ambulation in some patients, and also those with heart failure. We recommended the point-of-care ultrasound scanning for only classic indications and only when the result would alter care. I'd like to thank all of you for listening to this discussion, and stay tuned for more information at COVID-19 at veinforum.com. Thank you very much, everyone, and stay safe.